I'm wondering, with the use of technology, things like machine learning and AI, being used to both analyze past clinical trials and also being implemented just in real time, what we're finding, as we mentioned, with mutations and epigenetics, personalized medicine is getting really dialed in. How do you see that or hope to see that evolve in the future? And as far as applicability goes, we have this kind of hesitance to join clinical trials across different demographics. So how do you see the role of technology? How do you see the role that technology plays in all of this?
Yeah, I think technology is here, right? AI is here, whether we want to use it or not. And I think we have to figure out how to work with it and how to use it to our advantage. And I'm hoping that, one of the things that will evolve is really the evolution of that personalized medicine, right? Being able to understand who really will benefit from a treatment, right? Based on biomarkers and genetics and understanding which population truly needs and where we can escalate, where we can de-escalate. And I think, these have been some of the questions too that have been raised with the presentation of these studies and we'll talk about this with Destiny Breast 09 next, but does everyone need that regimen? Or can we start to figure out, based on certain mutations of the tumor, based on extent of disease and disease burden, who needs it? So it's coming, but it's going to take some time.
Great. So yeah, that leads us to our next trial.
Yeah, so Destiny Breast 09, so this one is for HER2 positive metastatic breast cancer. And the standard of care for HER2 positive metastatic breast cancer has been unchanged since 2012. So for 13 years, we've done the same thing. We've done a taxane with Herceptin and Perjeta, and after a certain point, we can drop the taxane if the disease is stable and continue on Herceptin and Perjeta as maintenance. And if you're hormone receptor positive, we add in endocrine therapy. And in the San Antonio Breast Cancer Symposium just this past year, we saw the PATINA study, which looks at adding a CDK4/6 inhibitor to endocrine therapy. And so now we have the Destiny Breast 09, which looks at TDXd, which is an antibody drug conjugate, trastuzumab deruxtecan, in first-line metastatic breast cancer rather than in subsequent lines that we currently do now. So in the study, they had 3 arms. They had TDXd alone, which is not presented in this analysis, TDXd with Perjeta, and THP. And what they found was that TDXd with Perjeta improved progression-free survival from about 26.9 months to about 40 months. So improvement in progression-free survival. And the challenge here is that, again, does everyone need it? Because you have to think about side effects. We have to think about with THP, we can drop the taxane, and Herceptin and Perjeta, people can continue on that. Whereas here, they're continuing on TDXd. We have to think about the long-term side effects, the risk of interstitial lung disease, which is about 12%. And where does endocrine therapy fit in, right? And where does the PATINA study fit in adding that CDK4/6 inhibitor? So there's still a lot that needs to evolve in this study. They did find that there was a higher proportion of patients with TDXd plus Perjeta that had a complete response. And in the discussion today, they raised the question, which I think is what we're all thinking is there going to be a point where we kind of do an induction with TDXd and then maybe switch to HP as maintenance? And there is an ongoing trial to answer that question. So I think great information raises questions about what is that going to look like in the clinic? Is it for everyone? Are there certain subsets of patients that might benefit? And so this is our first analysis. So there's going to be things that evolve and trying to figure that out and really talking to patients about goals. And I think so great information. I don't necessarily think that everyone's going to get TDXd with Perjeta right now, but who knows? I think it's going to evolve. And again, it comes back to insurance and cost and whether it will be covered. And again, we always have to think about side effects and what living with metastatic breast cancer really looks like, and how do we help our patients do it the best that they can.